TopMedTalk.
Hi, it's Monty Mythen here, Editor-in-Chief of TopMedTalk. Welcome back to Sydney, Australia. We're coming to you live from the ANZCA ASM, that's the Australian New Zealand College of Anaesthetists annual scientific meeting, with this wonderful booth generously given to us by the ANZCA, by the Australian New Zealand College of Anaesthetists, and supported in part with an unrestricted grant from 3M, who are just next to us in the trade exhibition here. If you get a chance to pop by, we're right next to number 79. So it's my pleasure to be talking to two new guests. That's Prof. Rob Sanders and Lis Evered, Prof. Lis Evered, of which I'll introduce them both in a second. I'm going to start with Lis, and what we're going to be talking about today is neurocognition, particularly in the context of after surgery and major anaesthesia. The last time we spoke about this, Lis, was when we recorded an interview with you in Prato in Italy. I'll come back to that in a moment. But first, could you start by introducing yourself or reintroducing yourself and telling us what you're up to at the moment?
Sure. Thanks so much for having me, Monty. This is great. So I am currently Associate Professor of Neuroscience in Anesthesiology at Weill Cornell Medicine in New York. I still have my appointment at the University of Melbourne, and I still have ongoing studies in Melbourne. So principally what I'm interested in or what our group is interested in is looking at the sorts of cognitive issues that arise associated with the perioperative period. In particular, we're interested in postoperative delirium and the predictors for postoperative delirium and the impact on longer-term cognition and progression to dementia. We're doing a lot of work looking at biomarkers and other sorts of possible intervention strategies, including both pharmacological and non-pharmacological interventions that certainly are advocated as helping, but we're really still missing the level 1 evidence to support that.
So I'm going to take you back for a moment to that interview that we had in Prato in Italy at the clinical trials meeting run by Monash University, led by Professor Paul Miles and colleagues. And then myself and Desiree Chappell interviewed you because we were in the wake of the Balanced trial. Could you tell us a little bit more about the Balanced trial for a second?
Yes, so the Balanced trial was a large multi-centre international study looking at targeting a light anaesthesia or a BIS of 50 compared to a deeper anaesthesia with a BIS of 35. And the primary outcome for that study was mortality at 1 year. Yeah. These were patients having major non-cardiac surgery, and there were over 6,000 patients in the overarching study, and there was no difference in the outcome between those two groups for the overarching study.
But I think we took a big takeaway from that was another way of repackaging it is to say it's okay to run the lighter level of anaesthesia, and therefore inferred in that is you're giving fewer anaesthetic drugs, which must be a reasonably smart thing to do, even if it comes to saving the money for the anaesthetic drugs. Is that oversimplistic, or is that?
Look, it's a really interesting point. Certainly in the entire study, there was only one case of awareness. Yep. So I think we can confidently say that you can target a lighter anaesthesia and not be at risk of harm. With regard to whether or not that's something we should be doing or not, I think that there's obviously a whole host of issues to consider, and we know that older patients in particular require less anaesthesia to achieve a similar level in terms of depth of sedation. But
who knows? So I'm going to come to you, Lis. At the time when we interviewed you in Prato, we were waiting with bated breath. You were teasing us. I think you may even know the results at that stage, with a sub-study that's now been published.
Yes, so we undertook a multi-centre sub-study looking at postoperative delirium. Intuitively, as you've just mentioned, if we give less of the agents that have an effect on the central nervous system, intuitively we would think that is going to have less of a detrimental outcome on something like cognition. In fact, what we found with the delirium sub-study was we did see a reduction in the incidence of delirium in the lighter anaesthesia group. And so I think that's a key outcome. It's a really important finding, and it was a robust finding. Some of the issues that we faced with that were that there were some geographical differences and perhaps cultural differences, and we undertook on the back of that a further meta-analysis of the other work, including the New Balance sub-study, and we found that whilst there was a difference, it's a fragile finding. And so we still really don't have definitive evidence of whether lighter anesthesia reduces delirium, although it certainly looks to be the case. And then there comes the question of, well, if there is no harm associated with lighter anesthesia, perhaps, as you say, perhaps that is something we should be pursuing. And it's such a nuanced field, and I'm talking this afternoon on a bit more detail about this, but there's so many other factors to consider, and it may be coming down to underlying vulnerabilities within specific patients that we don't understand. There's a lot of work looking at the spectrogram, so in fact it may be more about monitoring the spectrogram and not simply looking at a number that tells us some sort of guidance about depth of anaesthesia.
So that's looking at the whole EEG signal and to see if there's an inter-individual response to the drugs. As I remember in Balanced, was it all vapor anaesthesia?
Yeah, all of the patients had sevoflurane.
So it's all the GABAergic pathway, and that's another variable to be considered.
Yeah, so I think the two big questions with regard to delirium that's or post-operative delirium that still remain are a TIVA anaesthetic or an intravenous anaesthetic as opposed to a volatile anaesthetic. Dose is important, and whether or not EEG monitoring plays into that.
So one of the things I remain a little bit confused about, on the basis of the fact that the vapor anaesthesia drugs in particular are very sort of on-off, if you see what I mean, you breathe them in, you breathe them out. Pathophysiologically, why would one think that they would cause post-op? I mean, I can see there could be a hangover, for example. I get that bit. But if you go further down the line, what's thought to be the pathophysiology of why the anaesthetics might?
So it's a really great question, and I think one of the key findings in the work that we have to date is that actually the inflammatory response that we see with patients exposed, or animals and patients exposed to these drugs, actually is associated with the surgery more so than the anaesthesia. So I guess that suggests that perhaps whether or not they're volatile or intravenous is going to be less impactful. With regards to the pathophysiology, we just don't have an answer for that at the moment. But I think there's some really exciting work looking at biomarkers that is going to help inform that.
We'll come back to that in a second. So I'm going to bring our second guest in, mentioned him earlier, Rob Sanders. Was that Rob? Great to see you again.
Thank you very much for having me.
Thank you. So the first time we met, you were in the UK. I think the second time we spoke about the subject matter, you were in the USA, and now you seem to be in Australia. Tell us about that.
Well, I think circadian rhythm must be key for key importance for delirium, so maybe I'm testing that. I've been on a bit of a voyage, and it's been a great series of experiences for me. Great to be at Imperial, then UCL in London. I've got some real grounding and scientific background there. Great experience for 5 years in Madison, exploring mechanisms of delirium. And
Madison, Wisconsin.
Wisconsin, in the US. And then I've now been in Sydney for a couple of years, and really getting bedded down here and beginning to understand the cultural scene and the research scene in Australia. So it's very exciting times.
Now, not only because I have trouble sleeping sometimes, but I have read your PhD thesis.
Oh, you have?
A longer story for another day. But at the which you did at Imperial College with Professor Mervyn Mays, as I recall.
Yeah, and Tracy Hussle. Yep.
Okay, great. And what I took away from reading that and the papers that are associated with that is kind of convinced me that the major pathophysiological component that started to make sense was what we call inflammation, which is, we can talk about what inflammation means from the point of red hot, swollen, tender, but the sort of modern version of inflammation, which is certain mediators being in the bloodstream and upregulating certain proteins in different places. Expand on that a little bit?
Yeah, so specifically with relevance to delirium, one of the key predictors that we see in the postoperative phase that predicts delirium is a rise in inflammatory biomarkers. So something to do with how systemic inflammation modulates neuronal activity is key for disrupting cognition to the point where a patient can become frankly confused. What the model we have of the brain is that the brain is a series of modular structures which should share information in the natural normal setting, hopefully now. In the setting of that inflammatory soup, somehow that integration of information across those different modules in the brain becomes fragmented, and you get this, what we call a cognitive disintegration in delirium. And we're really now at the point of trying to work out, well, what is the mechanism through which those inflammatory mediators and what precisely are the key inflammatory mediators that are critical to transducing that effect?
Because Liz was referring to this earlier. If we put together the combination of surgery, which is a major pro-inflammatory insult, the bigger the surgery, the bigger the pro-inflammation. There's the response of the individual, and then there's, putting that in the context of the type of anesthetic, the depth of anesthetic, and then things like hemodynamics, blood pressure, brain oxygen saturations. There's a lot of factors in there, but inflammation seems to shout the loudest.
Yeah, I would agree with that. I mean, partly there's some collinearity. The patients who bleed or have post-op hypotension are also the patients who have very high inflammatory markers often. And often they're the patients who've gone through the most significant or severe surgery. So there is some collinearity we need to unpick further. But when you look across these sorts of mediators and try and compare them, the shining light amongst that is inflammation. And I think that's not necessarily a new concern. I think for decades, people have been concerned about perioperative inflammation. But I think what the challenge is to work out how we can modulate that, because some inflammation is obviously beneficial for wound healing. The right type of inflammation at the right time is what we're looking for.
Okay, so, historically, for a long time now, we've been talking about things like TNF and IL-6, pro-inflammatory cytokines, and then there's the anti-inflammatory cytokines. But we have a tendency to look at those in blood, because blood is the easy place to look. Liz, are we looking in the right place?
Well, that's a terrific question. So for a long time, we looked at CSF, cerebrospinal fluid, because that's where we could identify sensitively the levels of these sorts of inflammatory biomarkers and Alzheimer's disease biomarkers or biomarkers of neurodegenerative processes. And with the innovation of the Simoa, the single molecule assay in the last 10 years, we've actually been able to move to using blood, plasma or serum because the assays have become so sensitive. So there really is still two groups of thought about whether or not what we're seeing in the plasma is truly reflecting what's happening in the central nervous system, and what proportion of that activity is being led by peripheral inflammation as opposed to neuroinflammation. But we've got some good data from our studies where we've looked at CSF and blood biomarkers. And for most of the biomarkers we've looked at thus far, we're just in the process of writing up this paper, we have found quite good correlation between the CSF and the plasma, certainly for the neuronal injury biomarkers. Inflammation is perhaps not quite as closely correlated, but I think at the moment there's good evidence that peripheral inflammation leads to neuroinflammation, and we are seeing a picture that is reflective of something that's happening in the central nervous system, even in plasma biomarkers.
And we think of our own experiences of life. I mean, elderly people getting urinary tract infections, for example, they can go, I don't know if it translates everywhere, doolally. It's very tangible. That, gosh, it's amazing how bonkers old people can go with infections, for example.
Oh, absolutely. I mean, UTIs are well known for, being associated with confusion. And I think in nursing homes, it's probably the first question. If granny's a bit confused, that's the first thing you look for. So I think that is quite well known. And so this is consistent with that. In terms of what we see perioperatively.
So Rob, if it's inflammation as the primary culprit, why don't we just give a big dose of steroids and it all goes away?
Yeah, the steroid question's really, really intriguing, and I wish I'd known you were going to ask me that before you asked me that. But here's the limited that I know about it, and it's something which we started exploring, and it's particularly in discussion with Stefan Dielman, who's also at University of Sydney and Western Sydney University, who has done a lot of work with perioperative steroids. And one of the intriguing things about perioperative steroids is that they do reduce that systemic peripheral, if you like, inflammatory response. They don't seem to protect the blood-brain barrier in the way that we would expect in concert with that. And you still seemingly can get neuroinflammation in the setting of that steroid, those peripherally administered steroids.
Okay.
One of the reasons is that glucocorticoids actually have alternate signaling pathways in different tissue regions, and that's due to presumably, it's a while since I looked at this, but post-translational modification of receptors and things like that. So what we might expect in the bloodstream with the steroid doesn't necessarily translate to their tissue effects. And that might be why we haven't seen major benefits for steroids with post-operative delirium. But I think that's another question that could be answered, further, and we need to do more mechanistic studies probably to define those pathways more clearly, because it is an intriguing challenge to the inflammatory hypothesis. One would have, as you've just proposed, glucocorticoids would be an obvious first step.
Any other obvious candidates?
Well, yes. I mean, I think it's all about investment. I mean, you could definitely make arguments that we could use some of these antibody-based therapies for immunomodulation. They would have some specific benefits, such as a long half-life. You give a single dose of the drug, you could expect benefit over days. The question is how you dose those safely in the perioperative period. Would you alter some of that good wound healing type inflammation that you get as a later effect? And whether we need to more precisely identify those who would benefit from those therapies before embarking on a large trial, because those therapies themselves are still expensive.
Rob, where do you, loaded questions, but where do you stand from the point of view of post-operative cognitive dysfunction being an accelerator of cognitive decline, of accelerated dementia, however one chooses to phrase it?
Well, I'll probably reference my answer to that around delirium and as a really extreme form of post-operative neurocognitive disorder. We have evidence stimulated by some early work that Lis did actually, but there's some evidence that delirium is associated with increases in neuronal injury biomarkers, that the rise in neuronal injury biomarkers is proportional to the severity of the delirium. And that's associated also with the peripheral inflammatory response, which is a causative or a probable cause for delirium. So we feel pretty confident that there is some form of neuronal injury that occurs coincident with delirium. The exact mechanism needs to be refined. We've recently showed that those neuronal injury biomarkers also change with MRI-defined covert stroke. So we've got MR evidence to support those neuronal injury biomarker changes. So we know that there can be acute forms of neuronal injury, and we know from large epidemiological studies and even small anecdotal reports that delirium is associated with can be associated with rapid cognitive decline and the onset of dementia later on. So there does seem to be convergent evidence that delirium could drive a later cognitive decline, but I think we need a broader, larger scale approach to understand and quantify that more precisely, to how much we can attribute. And presumably this is a cumulative hit as well. So yes, every time you have surgery or you have a UTI or you have another inflammatory hit, you're getting this. So it's not, when we're thinking about therapies, we're thinking about the perioperative period, but there, as you mentioned with UTIs, there's an opportunity there for anesthesia and perioperative medicine to contribute more broadly if we do develop the right therapeutic approach.
So Lis, why are we not seeing more delirium/cognitive decline, long-term dementia research being done around the time of elective surgery? Because it seems like a great, you've got before and after and an insight.
It's absolutely right. I mean, in lots of ways, the perioperative period in older individuals is a fantastic model for an injury to the central nervous system that we actually know is going to happen in a significant proportion of people. We need the longer term follow-up of these patients, and these studies are really expensive, and I think there's a reluctance to fund things that take a long time to answer questions. we know in medical patients, in intensive care patients, in institutionalized patients, that delirium is associated with increased mortality and increased delirium. And by extension, we anticipate that will be the same with the delirium we see in the perioperative period. We're really lacking the long-term studies to do that. We're working on a long-term non-pharmacological intervention for delirium at the moment. And there's some good work just recently put out by Gideon Kaplan and Sharon Inouye, 2 separate papers, demonstrating quite clearly that post-operative delirium contributes to the prevalence of dementia in the community.
Okay. Yep.
And I think we have to work on seeing the perioperative period as a period where we can learn so much, as opposed to the patient goes siloed off to the hospital and comes back again, and we pretend that never happened.
There's a big long-term efforts. We're getting close to the end of our time. We could speak about this for hours, which would be lovely. I want to jump into amyloid for a second, because it's even, the presence of amyloid and whether or not it's a true related, true unrelated. We'll expand on all of that in a second. But also listening to the radio more recently, there are new therapies that are being proposed might be able to halt the progress of dementia. What's the amyloid story, Rob?
Well, with amyloid and dementia, obviously there's been this amyloid hypothesis that was defined decades ago with the association of Alzheimer's disease and with amyloid plaques and neurofibrillary tangles in the brain.
So that's if brains are looked at necropsy.
Yeah, they
can find this unusual protein which can deposit itself anywhere in the body.
Yeah,
often
right.
Following inflammation. Is that right? It's quite a sticky protein, and that's amyloid.
And it's made up of different monomers which are difficult to clear, which is why you can get plaque formation, particularly in the setting of diseases associated with different mutations in clearance enzymes, for example.
So people have found it there in the brains of dead people when they've looked at them closely, and they've said, well, if it's there and they had this dementia and it wasn't there in people who didn't have the dementia, they put 2 and 2 together and they've said, well, it must be causing it.
Yep.
Do you think it's causing it?
Oh, I don't think I'm going to be drawn on that in this environment, Monty, but it's a wonderful question. What I will comment on is that it's been associated with delirium too, that we know that there's a clear link between vulnerability to delirium and having Alzheimer's disease. And so that's an open question for which we got NIH funding a few years ago to try and investigate. And we've published some recent biomarker work using different soluble biomarkers, which due to the advances in technology that Liz mentioned earlier, these Simoa assays means we can now measure in the blood as a reference for what's happening in the brain. And there's been some specific developments with phosphorylated tau, which has allowed us to use that assay from the plasma to reflect on what's happening in the brain. Now, it's known from the geriatrician literature that chronic levels of those biomarkers are associated with, for example, PET imaging markers of amyloid in the brain, and then subsequent post-mortem analyses, as well as cognitive performance. What's intriguing in the perioperative period is that these phospho-tau 181 levels and some data with 217, now a different isoform, have been shown to rise in the blood. Now, we don't know exactly what the significance of that is, but it could mean that there's dynamic processes occurring in amyloid synthesis, deposition, or clearance that are occurring in the perioperative period that, with a cumulative load of inflammatory events or surgeries, could become significant. We don't know.
So you talked about amyloid clearance, because the last time I learned about amyloid properly was when I was doing medical school finals, and I obviously didn't learn about it very well at that stage, or maybe we didn't know much at that stage. But the implication at that stage was that once it was there, it stayed there. But you mentioned the word clearance. Yeah. Is there a suggestion that it comes and goes then?
Yeah, well, it certainly can be levels can be modulated, and microglia, for example, play an important role in both the development of plaques and their clearance. And so there's a possibility that perioperative changes in inflammation, particularly the very profound changes we can see with major surgery, could influence those levels. We have just published a different paper with measuring amyloid beta in the plasma, and we saw very transient changes in amyloid beta associated on post-operative day one, which could reflect that larger scheme inflammatory response. The amyloid beta changes in the plasma, though, have really been superseded by these phosphorylated tau assays, which seem to reflect amyloid and tau disease in the brain. So we really need to look to those, I think, to sort of understand this more clearly.
And Liz, we've been hearing recently about some treatments that, as I remember them, they've got a MAB in them, which implies the fact there's some sort of antibody thing going on. We were joking earlier about the latest one sounds a bit like doner kebab, but it's not doner kebab. But always hard to pronounce things with a MAB in them. Can you tell us a little bit about how they're supposed to work?
Look, I don't understand fully the mechanisms behind how they work, but I think one of the key things in the Alzheimer's disease literature where these sorts of studies are taking place predominantly, the really important thing that we've noticed, and again, going back to the clearance, is that there are studies where those sorts of drugs can clear amyloid beta plaques from the brain. Okay. That has been shown to be possible. What hasn't been shown is that the clearance of those plaques is then associated with a return of cognitive function. Gotcha. So whilst there may be some sort of statistical improvement in cognitive function, at the moment there's very little evidence that would suggest that there's a difference enough that even the patient or their family would be aware of that difference. So I think perhaps the damage is already done once the plaques and okay. As Rob was saying, the down the track issue with the tau phosphorylation and the tangles that we get from that, it may be that once those plaques are laid and that downstream effect has taken place, it's too late.
Which brings us back to the possibility of preventing that. Would these drugs prevent it as well if they were given around the time of surgery, for example? Could they? Well,
look, this is a really interesting area, and I guess that at the moment we don't know. One of the issues is being able to identify the really vulnerable patients, and so we can offer those patients these sorts of interventions. It may be that if there is an exacerbation of an underlying neurodegenerative disease, that if we could implement these sorts of strategies, that it may be possible, but I think we're a bit of a way off that at the moment.
So if we can determine the very susceptible individuals, there might be part of trying to prevent accelerated.
Yeah. So at the moment, certainly there's been a bit of literature. So there's a paper by Livingston who they did a Lancet Commission on Dementia in 2017 and then updated it in 2020. And so for dementia in the community and delirium, either post-operatively or in the community or in hospitalised patients, at the moment the general feeling is that prevention is the only way to avoid these deteriorations from occurring.
Rob, we're coming close to the end. Anything practically we can do today?
Yeah, I think that the practical answers, if we return to delirium, I suppose, and thinking about perioperative brain health in general, are around the simple measures that Liz alluded to, those non-pharmacological strategies, supporting the patient, reorientating them if possible, providing glasses, hearing aids, simple measures like that, things that maybe the anaesthetist doesn't reach to in the first port of call. But I think those sorts of elements are very important. Basics of perioperative care, doing that well is important. Pain management, looking after observations, hemodynamics, the stuff that we would consider our bread and butter, but special attention required. And then ruling out causes that we might not be thinking of immediately. Have we given anticholinergic drugs and surreptitiously or without really paying enough attention? Or is there an infection or some other process that we could try and intervene on? But in terms of magic bullets, my drawer's currently empty, and I'll be looking to Liz to provide some bullets for us.
You just raised something that is kind of related. Something I've advocated in my talks for a number of years is the idea that we actually allow older patients to be accompanied to the anaesthetic room, the operating theatre, by a family member, and again, that family member is in the recovery room. And Idit Batot, the international visiting speaker at this meeting, talked this morning in her plenary about a study she looked at 100 elderly patients who were escorted into the OR and then seen immediately in recovery, and all bar one of them had only positive things to say about the experience, and that it made a difference to their ability to orient immediately after, on emergence from anaesthesia. So I think that's a lesson we could learn as well.
So my takeaway from the training that I got on sort of surgical intensive care unit, I've mentioned it on TopMedTalk before, but it stuck with me, was, dentures, hearing aids, glasses, pain, bladder, bowels, if you see what I mean, and then try not to irritate them, and a familiar voice and a friendly touch takes you a long way down the track. Is that fair? And then cross off anything that's anticholinergic, of which there's a lot of. Is that about it?
Pretty much everything.
Is that?
I think that's
Absolutely.
where your training is where we're at, and we're looking forward to the future where we'll have something to add. But at the minute, we're still learning about it. And everyone needs to give us time to learn about it because it's an important problem.
Rob, what's your next paper coming out going to tell us?
Well, on this topic, I don't know. We've got some interesting things about connectivity in the brain with delirium coming out. We've got a major analysis of UK Biobank of 500,000 records with cognitive data, hospital exposures, knowing what admissions have occurred and how they contribute to cognitive decline. And 50,000 patients have MRI scans. So we're hoping to get really into the neuroscience of that. So there's some good work coming, but I'm going to wait for them to. I want to be invited back, Monty. So.
You're very, very welcome. Liz, what's coming down?
So one of our major studies is non-pharmacological interventions. Really what we're talking about is what we've termed brain ERAS, really optimising patients pre-operatively, peri-operatively in the hospital and following them post-operatively. We're writing up some work looking at biomarkers in cardiac and non-cardiac surgery patients. And one of the things I'm really excited about is that I'm just putting the finishing touches on a paper which looks at classification of neurocognitive disorders using the old terminology of postoperative cognitive dysfunction and the more recent terminology of neurocognitive disorders in over 1,000 participants. So it'll really tell us where we are on the map of what we're measuring, which is really critical to the field.
So, Liz, if I may, Rob, thank you very much indeed for your time in sitting down with us. So I just want to say thank you again to ANZCA and to 3M for their sponsorship, for being here at this wonderful meeting and the ability to do these interviews, and for our other sponsors, in particular Edwards, GE and Medtronic. Without your sponsorship, we couldn't keep this free, open access medical education for the world, coming up on 2 million downloads.
Wow.
Now, which is great.
Yeah,
impressive.
Just shy of it. You might take us over. If you tell your friends and family to get downloading, we might get there today.
We'll be doing that
We're
immediately.
doing that, exactly.
Yes, that's right.
And we're signing off for the day. We'll see you all tomorrow. Thanks very much. Good night.
Thank you.
Thanks so much, Monty.
Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.